Uh, Good evening and good morning, everyone, dear viewers. Thank you for all joining us on this special and very important topic, which was close to Dr. Shovan. He actually been with us for a long webinar previously and was very interested in preparing this webinar on the upper limb rehabilitations using the Frugal innovations. I think he has patented many of his innovations, and of course, he's doing a lot of wonderful research in this topic. With us, we have the moderator, Ms. Aditi from US. I think she's a wonderful occupational therapist and also a great teacher and a mentor. Is pioneering also in this field with a lot of research and academic activities. Along with us, we have Ms. Paurvi Kedia and Vinoth. Both of them are equally well experienced and dedicated hand therapists doing their respective job in Chennai and also in Bengaluru. I suppose they have their own institutions. I think it's a great time now that we all join together for a common and an important and essential vital aspect of rehabilitation. Most of the surgeons, we find that 50% of the job is complete once you operate, but then the main component is rehabilitating them and then getting back to work, and that is more important vital job. And we especially we are in glove in hand with the therapist to see the improvement and also the outcome of this patient. So with this brief introduction, I'll introduce to the audience the moderator, Ms. Aditi Tuell, to take over this program and then to continue introducing the speakers and let us give a start and give us the best shot. Thank you for all joining us. Ms. Aditi, can you please start this program?
Thank you, Dr. Terrence, for those kind words. It's a great honor to be invited to this platform, and it gives me immense joy to introduce one of my favorite teachers of all times, Dr. Shovan Saha. He holds a master's degree in occupational therapy and a PhD in assistive technology outcomes. He's interested in hand rehabilitation, splinting, and low technology devices. He has authored several articles in national and international journals and has contributed chapters to several textbooks, including the renowned book for hand and upper extremity rehabilitation, a quick reference and guide. We very lovingly refer to this book as the Purple Book, and I did use this during my CHT exam prep, and it was so wonderful to see a chapter from, a familiar face. He's also the recipient of AIOTA trophies, Professional Excellence Awards, FACOT Award, the prestigious Madak International Award at AOTA. He's been awarded the Best Teachers Award at MAHE and is also the recipient of the Manipal Foundation grant for his PhD and the MAHE Innovation Award. He has several patents in line that he has filed. He is a teacher and has developed a specialized life training program in hand splinting and has trained over 60 batches of occupational therapists. He is the designated hand therapy educator at IFHT and is a technical mentor for med tech innovators affiliated to the Government of India. He's been a speaker at the World Health Organization in Geneva on assistive technology. He currently is the president for the Indian Society of Hand Therapy. And with this, I would like to hand over the mic to Dr. Shovan Saha. His presentation is titled Frugal Innovations for Focused Outcomes of Dysfunctional Hand. Sir, go ahead.
Yeah, thank you. Thank you, Aditi. Am I heard clear? Yeah, thank you. So at the outset, I would really appreciate Dr. Terrence for this wonderful opportunity. It is because of him we could put this event together. Thank you so much. Thanks, Aditi, for that intro, and thanks to my dear students who would be speaking later on for participating in this joint endeavor. So we have kept the theme of this webinar as upper extremity rehabilitation through practice of frugal innovation. And as it's been stated, my topic is on frugal innovations for focused outcome of dysfunctional hand. Now, frugal innovation basically are some simple solutions that we need to develop because of a very simple reason that there are definite resource concerns, in a country like India. So how do we optimize, whatever resource are at our disposal, right? So we need to have these innovations which are customized and they are being met out to the patients whose needs often are quite unique, quite challenging. And me, from my personal experience, often have seen that things that can be brought from abroad often doesn't work here. Okay, so we need to have a mechanism by which we develop we develop devices at our place so that the usability of those devices are far better, compliance is better. So it is on those lines I have been working, and also I impart training that way. Customization is a huge thing. Okay, customized technical solutions are an absolute mandate for a precise, focused, and tangible outcome. So when I say tangible outcome, it essentially means that it has to be visible through the eyes of our clients, through the eyes of our patient. It is not sufficient that we clinician, we say that we have achieved sufficient outcomes. It is they who have to endorse that. Okay, so that is absolute critical to this journey of frugal innovation. We generate the need. So it's a whole process of you know carrying out this entire endeavor. There are different steps to it. We generate need, we manage resources, marketing, evaluating, conceptualizing, design, develop. We handcraft them. We have a setup in our department. So we handcraft them, we try them, negotiating with a whole lot of stakeholders. We have to sell them. We work in a corporate hospital, semi-corporate hospital. So, we need to negotiate with a whole lot of stakeholders, and they have to agree to buy them. Okay, obtain inputs. We make these devices right in front of the patient. Okay, so that at all steps we get their inputs, and we go on investing these inputs into our design, upgrade them, and then ultimately we aspire that someday our patients will be able to do with their physical ability, probably without those devices. So these devices essentially, they enter into their life, and we hope that someday it will move away from their life, and they will be able to perform things with their own bodily abilities. So all this happens by being inside an industry. Okay, so here we will be sharing, some of our experiences. So just a couple of quick slides on, some of the perspectives of which helps us guide through this process. So in front of you, this is a health tunnel. At the entry of this tunnel, most of the time it is the physician, and then the patient walks into this tunnel. There is a host of professionals who engage with these patients, modulating, maneuvering, refining the individual's abilities. And then at the exit point, or at the mouth of this tunnel, essentially it is an occupational therapist Why so? Because as they exit, they walk into the realm of the functioning. Okay, it is this functioning that defines us, that defines ourselves, our existence into the society. You know, how do we do things? Are we able to do things the way society expects us to do? Okay, supposing eating, writing. So there are certain untold norms, the way you eat at home, the way you eat in public places, the way you write normally, the way you write before the exam. You know, so there are a whole lot of norms. And so when we say that we are rehabilitating, okay, are we ensuring that we are fulfilling these untold or unseen criterias which are often laid down by the society? So to be able to do that, okay, there is a need for these small, frugal, technological innovations which refines their capability. So there is a difference between movement and meaningful action. So in this tunnel, it is all about movement, but as the person exits and takes a giant leap once again back into their functional realm, there you need action. So translating movement to action is something that is absolute of critical value. So to be able to translate that, we take help of these devices. So trying to draw and so here you have in this visual you can see these are OT two alphabets, right? So to the world it is OT, but when I look at it through the eyes of you know restoring those abilities, okay, it is no more OT. Okay, so O for me comprises of numerous pixels. Okay, each pixel has a role to play in that image. Okay, so I need to find out which pixel has a problem, and then we try to figure it out that can the work of those pixels be either temporarily or permanently be replaced with an innovation. Okay, so that is how we look at a function. Okay, but to the world, it is just OT. Okay, so once the function is restored, once again, it regains its shape as OT. Now, how does it look like in real life? Okay, so here you can see it is about this part of the country, cashew factory is a common, small scale industry. So they have to, one of the job that is required is to scrape the cashew with a scraper. So you can see how this is a normal hand doing the activity. Okay, how seamlessly the cashew is rotating between the fingers. Now this is the affected hand. Okay, and you can see the hand is struggling to rotate the cashew. So when there is this struggle, okay, there are issues with it. Sorry. Okay, so these people, they are being paid based on how many cashew they would scrape. Okay, and the correctness in scraping. Okay, the accuracy in scraping, because while scraping, if they damage the cashew, many a times they have to pay for it. Okay, so those are the challenges that when I'm working with them, I need to keep that in mind. This is another example of wearing sari. Okay, as we all know, wearing a sari has numerous steps to it. So one of the step is making these pleats. Okay, so now when a patient will come to us and they will say that we have difficulty in putting on the sari. So like the previous visual, I have to find out which pixel is affected. Okay, where exactly is the how it is compromised. So I need to pick up those precise pixels and be able to replace them with certain technological innovations. So here this is a hand of a head injury patient. Okay, so you can see how that hand is struggling to coordinate, to make this pleat in a coordinated way. So this lady is desperately wanting to achieve that task, because otherwise she is dependent on either her daughter, and many a times her daughter is not at home, then she has to depend on her neighbors, okay, for this process. So now these innovations can be broadly grouped under two headings. They can be splint or orthosis and adaptive devices. Okay, so for an outsider, they all might look quite similar. Okay, because we all make them with the same material, same setup it is made, but they are quite different. Okay, so these are the standard definition. We can just skip through them. Now, when I say that I'm working with a frugal innovation, these are the characterization of these innovations. So they have to be, they are low technology, they are soft technology, and they are minimal technologies. So this is my framework of my work, the frame of my work. Okay, so low technology, they are essentially inexpensive, they are easy to obtain. Soft technologies are human areas of decision making. So these devices essentially are customized, okay, and they cannot be mass produced. That is one of the big challenge. Okay, so they take into account some of the unique needs of the individual. Okay, and those needs are used to create these devices. So although if we consider it from a broad point of view, supposing we say that the individual has difficulty in writing, I might have 10 patients and all of them have the same complaint of difficulty in writing. But the reason for the difficulty might be quite unique to every individual. So when we end up making these devices, they actually will be quite different to each other. So soft technologies and minimal technologies, they generally augment rather than replace function. So these devices essentially are used for the purpose of protecting an operated site, positioning, preventing, correction if there are a set of problem already existing. So there is a way, in a non-invasive way, in a conservative way, we can make changes, and of course functional. So making a device for neurological condition is quite different from physical condition, and making a device for pediatric condition is quite different from an adult. So these are some of my perspectives after having worked in this domain for quite some time. So you have occupational therapists who create and craft splint themselves have a different way of understanding movement restriction due to injury, immobilization, or spasticity. So for us, the meaning of movement restriction is quite different from people who are not involved into making these devices. So for common man, movement restriction, the word is very anatomical in nature, but for us, it is very functional in nature. Making a splint is no big deal, but making a change in the mind and body with a splint is a real challenge and is a big deal. The image that you see here, there are almost 22 2 items on this. Okay, and interestingly, it is for one single patient. Okay, so it is one single patient with a bilateral crush injury. And so this lady, she wanted, she's an anatomist, okay, and she wanted 3 things. Okay, she wanted 3 things, to be very specific. She said that I want to be able to open my car door and my office cabin door. I should be able to do dissection. Okay, and I should be able to write on the blackboard. So this was the terms and conditions that was set at the start of the journey. Okay, so each splint, okay, it is not possible that we hand over these all 22 gadgets in our hand like that. It is one splint given and that does the job. It is explained that this splint is given for this purpose and it has to do the job. Then it will go to the next splint. Then it will go to the next splint. And that is how, over a period of almost 1.5 years, these 22 devices were given to her and she went back. Okay, although certain compromises, but those little compromises, they do not hold that much weight on the face of when the person is able to successfully carry out those tasks. Those small compromises do not matter at that point as long as they are able to achieve certain tasks. Because in this whole process, there is an enormous amount of negotiation that happens. Okay, where it is made them to understand that there is a damage that has happened and it has to be accepted. Okay, it has to be accepted, but then there is a way to deliver this message to them, right? And so that message it becomes more acceptable when the person is able to achieve task bit by bit by bit. Okay, so making a splint is no big deal, but making a change in the mind and body with a splint is a real challenge and is a big deal. So when we create these splints, we consider ourselves creator of splints rather than maker of splints. Okay, so when we look at a splint or a device, to the world, they can visualize only the tip of the iceberg. Okay, but the real game is played, at the level which is below the surface of the water. The entire planning process. Doesn't matter how simple the device is. Okay, there could be a possibility that it has gone through a whole lot of thought process. Okay, a lot of trial and error, a lot of negotiation, a lot of yes, no, right? So constructing a splint is just the tip of an iceberg. Designing it is the iceberg below the water. We use at our facility, we use these 2 materials, predominantly metal and plastic. So these are metal in the form of aluminum strip, aluminum sheet. Okay, and plastic, they are low temperature thermoplastics. Aluminum is very convenient to us because it is locally available. But then there are certain constraints because it needs more skill to deal with the metal. And also the infrastructural requirement is little big as compared to plastic. But the challenge in plastic is, unfortunately, India doesn't produce plastics, this low temperature plastics. We have to import, and often we import from US, and it works out pretty expensive. And the other main concern about plastic is it has a defined shelf life. Okay, whereas metals, they last a much longer time. So these are the 2 materials that we use. Is our facility. Okay, so when Aditi was here, that time the splint room was different. Now it is different. It is big now. Okay, so this is a very busy unit in our department. It is almost like a nerve center of our department, whole lot of activity happening. So in the image, you can see these are the students. Some of the students have come from Bournemouth University, UK, to spend some time in that facility. So these are some of the highlights, state-of-the-art facility, only therapists make. So that is one of the key factor, because we believe that the more we dabble with the medium, probably the more we will learn and understand. So there is nobody else, it is we who make, I make, my students make, okay, we make it absolutely hands-on. Conventional, unconventional, static, dynamic, design almost around 2000 to 2200. Of course, now due to pandemic, this number has come down. We also make designs on the lines of tele-rehab. So we obtain images, visuals. Okay. So information technology has done a great help in this process. So we do make them. And of course, there is always a challenge when we are making these things remotely, okay, as compared to when we make live on the patient. So this is, this is the journey of a hand, how it comes to us, okay, and then it goes through a grooming process, okay, and during this journey, of grooming the hand, giving it a shape, giving it mobility, making it supple, helping it with regaining certain amount of sensation, okay, making the person becoming more acceptable to it, and we hope, we hope that finally we should be able to bring this hand near to a normal hand. So in this entire journey, in the backdrop, we have these devices, different kind of devices which will play very critical role. Okay, so this is a hand which is traumatic in nature. Okay, this is a hand which is neurologically compromised, and they are two different world altogether to deal with them. Okay, so this is the case with infantile hemi. Other image sharing, some this on this extreme left, it is a head injury patient here, head injury here. This is an infantile hemi for whose visuals you are seeing. This is a CP diplegic. Okay, so you can see how there will often be a mix of contractures and spasticity. So that is a challenge. Okay, because for spastic conditions, neurologically compromised patient, there are two variables essentially which complicate the matter. One is contracture and one is spasticity. So we have these devices which will provide with prolonged stretch in a way which the tissues should be able to accept that stretch. We never go overboard, because as we all know, spasticity is hyperexcited stretch reflex. So we don't stretch them too much. So you can see the designs are all compliant to all these things. So these are two different things. One is traumatic conditions, one is neurological conditions. Here I've just quickly put up some of the splints will be covered by my two other co-presenters. So I've just quickly put it for upper extremity. We make splints from head to toe. Okay. So in this particular slide, I've just kept it for upper extremity conditions. Okay, and some of the basic things. So here you have finger-based splints. This is a thumb-based. These are palm-based. Okay, this is radioulnar joint, forearm-based. These are all the arm-based for elbow, both extension, flexion. Again, so these are all forearm-based. Okay, static, dynamic, and these are shoulder-based. So we have expertise in coming up with meeting all kind of challenges as long as they are contractures. Okay, so that is very important for us to be able to distinguish between deformity and contracture. Okay, so because as long as they are contracture, there is always something for us. Okay, so these are some of the pre-post severely contracted limbs, lower extremity severely contracted knee flexion contracture. These are all head injury patients. Okay, so these splints, we can't make it of plastic, you need metal, because plastic, the inherent problem with the plastic is plastic assumes the shape that is offered to them. Okay, so it on its own, it cannot get a shape. It needs something to get a shape. Whereas metal, you can shape them independently. So that is the advantage that we use in conditions where the contracture is severe. Okay, spasticity is severe. Splints with external fixators, that is also another option that we this thing. So these are some of the variations. Pediatric splints, we try to catch them as young as possible. Especially congenital anomalies. The earlier we get them, we will be able to release a certain amount of tissues. So the patients are often better prepared for surgeries at a later stage. This is on this side, you have a quadriplegic, CP quadriplegic. Okay, so here if you see this, he wants to eat. He's a 14-year-old boy and he wants to eat. He has never done it by himself. And we do not know how many more years he has to wait for the hand to reach the mouth in a coordinated way. Okay, so you can see we have given an adapted spoon, but that was not enough. Okay, but when the spoon is combined with the splint, when the splint the splint is holding the wrist, the forearm in a particular angle. These angles are all studied. Okay, they are all understood in the context of this patient. So to the world, it looks the same splint, but minor variations in the angles they play the critical role. So here you can see, everything is written on the face. The struggle is written on the face. The struggle to reach this spoon to the mouth. Although this distance might be hardly 4-inch to 5-inch distance, but who knows whether he will ever reach this distance. So you can see here with all these adaptations, the spoon does reach the mouth. These are some of the functional aids. We are slowly coming out of the splint. So this is the hand of an engineer electrocuted. Okay, and the first thing he wanted is, can I eat? Okay, so this is an adapted spoon. So the spoon, so essentially what we do is we try to estimate how much ability is there in that hand. Okay, because it is a very critical balancing act. Okay, we have to ensure that we utilize the existing abilities. Okay, if you are not able to use the existing abilities, and if the device kind of overmasks, masks the performance, often there is a device rejection. Okay, so to estimate that ability and then match it with the device is of critical importance. So this is a spoon. This is a small little girl with bilateral congenital anomaly, and she can't open a bottle. And that was putting a big challenge for her to drink water in her school. So what she will do is she will drink water from home, and then she will go back home and then drink water because she cannot open a bottle. Okay, so this was what was given. This is for a triple amputee patient. This case came with an explosive injury. Okay, you can see the 3 fingers that we use for writing, thumb, index, and middle finger. They all have been removed. Okay, this is a partially amputated hand, an explosive injury. Now the obvious response will be, why don't you write with your left hand? Okay, but interestingly, this man he has come down from Tibet, and we have a place called Kushalnagar, okay, which is one of the biggest Tibetan congregation here in Karnataka. Okay, so he's studying the religious study. He's a Buddhist monk, and his religious compulsion was that he cannot write with the left hand. Okay, he cannot write. That was his compulsion. He has to write with his right hand. So this is how we made. So what we do is we try to capture the role of all the three fingers, invest it into the design, okay, and then make the ring finger participate and make him write. In fact, this is one of those devices that there was a series of 3 devices. This is one of them through which I got the American Occupational Therapy Association award. Okay, so he is a clerk in our local Taluk office, and he had to write. So you can see, again, it is a partially amputated hand. Okay, and so he needed a special pen, okay, a different kind of a grip, and that is how it was made and given to him. Now, this is a young girl who's, you can see the obvious limb length discrepancy, okay, and she had a concern that she wanted to help her mother in kitchen work, okay, and one of the concern was she had no control in the opening and closing of the hand, and as a result of that, she was always scared that this thing might spill off her hand, hot utensils. Okay, so that was this thing, that was the concern, and this is what we made for her. Okay, so I'll just quickly run through. So it is a sneak peek of what we do and how we do. Okay, so we all do it ourselves. So I'll just quickly run through. So now these are the 2 vessels. So we kind of simulate all these things because all this information has to be collected. The kind of vessel, the weight of food, so that the device that we make should support, the shape of the device, the weight of the device. So all those things are taken into consideration. So irrespective of whether the hand is open or closed, the device will latch onto her palm, whether it is closed or open. I think so. I'm running out of time. This thing. So this is another patient. You can see the full length king cobra, and he is a snake conservationist. And the other hand, if you see it carefully, there is a splint there on his hand. So he was in desperate need to go back, although it had its own share of risk, but he wanted to go back and he was desperate. And we knew that even if we don't do anything, this fellow is going to go back, okay, and do that because that is his hobby and that is only his source of income. So we need to look at, we had done a lot of study on a video footage of how he holds the snake. Okay, because we need to understand that we have to restore that confidence in his mind about that hand, about its capability. Okay, although the hand is compromised, so my device should be able to, restore that confidence in his mind. See how calm and how cool he is. I'm sure all those people who are watching this, if this snake slips under your bed, under your table, under your chair, okay, we know what we are going to do. Right? So, but this person maintains that calmness. So my device should be able to, should enable him to do that. So that is the job of me as a designer when I'm creating this device. Okay, I think so. I'm running out of time. I'll not play the video. These are, okay, maybe one of them. So these are 2 students, 2 different students, congenital anomalies. So they came up with a problem that they have difficulty in handling the scale. Okay, so it doesn't stabilize. They put a line, it gets, there is an error. Again, they have to keep redoing. So that was one of the concerns that they stated. Okay, so this is, you can see this is how she handles. So it is very obvious that there will be, the scale will move away. Okay, so this is how the device is. Okay, so yeah, this thing. Yes, I am almost done. He's a stockbroker, and crush injury and typing for him and typing with certain speed was a problem. Okay, that was a concern. After this injury, he was typing with one hand, and that was really was a big concern for him. Okay, so then this was because the problem was when the hand is landing on the keyboard, it is pressing multiple keys. So that was a problem for him. So here you can see, okay, in the backdrop we are counting the speed also. So he later on he came very close to the way he used to type before. So this is another visuals of, as I told you, ultimately we aspire that our patients should be, done away with all these devices. So this is one of those examples, where this man, multiple this thing. Okay, so he is a boatman. Fishing industry is a big thing here. Okay, so he is a boatman and he carries around 15 fishermen on the boat into the high seas, the Arabian Sea, and so the owner of the boat refused to take him back once this accident happened. Okay, because he didn't want to risk the lives of 15 people on the high sea. So that was a real tragedy for him, because that is his only, livelihood, source of livelihood. And that is when we chipped in. And this visual that you are seeing is he is giving us a ride onto the high sea for us to see that everything is working fine. So those are the images of some of my postgraduates for the field visit. Yeah, with that, I come to the end of this presentation. This visual is from the executive boardroom, WHO headquarters. Thank you. With that, I come to the end. I'm sorry for overshooting the time.
Well, thank you, Shovan sir, for that outstanding presentation. So our next presenter is Paurvi Kedia. She's an occupational therapist by profession. She graduated from Jaipur Occupational Therapy College, and she holds a master's degree from Manipal Academy of Higher Education with a specialization in hand and musculoskeletal conditions. She also has a certification in splinting. Currently, her entrepreneurial journey led her to setting up her own enterprise for hand rehabilitation. She's the proud founder of SB Rehab in Bangalore, and she's also the co-founder for Assist Aid Healthcare Private Limited, a medical device company based out of Bangalore. Her area of interest is hand rehabilitation with emphasis on splinting and creating effective tools for activities. The title of her presentation is Splints and Therapeutic Aids in BBPI, a therapist perspective. So with this, Paurvi, I hand it to you.
Yeah, hello. So am I audible, ma'am?
Perfect.
Yeah, sure. So thank you so much for your kind introduction, and thank you, Terrence, Dr. Terrence, and all my panelists for supporting and calling us for, giving this talk. So here I start. As my topic title says, Splint and Therapeutic Aids in Birth Brachial Plexus Injuries. And it's my perspective, how I have seen them, how I have tried to put in a little bit of creativity and help these patients. I have been seeing quite a lot of brachial plexus injuries, burst-related brachial plexus injuries. And as a therapist, the common problems I have seen is external rotation, internal rotation. They are related to shoulder flexion, abduction, elbow flexion and extension, pronation and supination, wrist flexion and extension, obviously grasping, and there are co-contraction of various muscle groups. So these are some common problems we all have seen in kids, and they all come up with these problems. And how do I help them in these problems? So the challenges in treating children are really they're not like adults. They will not understand the need of doing exercises. They don't understand that this is something which is really important for them, and because it's happened at a really early age, they have to continue it for a very long duration as compared to traumatic accidents. So the problems which we face while treating them is there might be a lack of cooperation from the child itself. The willingness to do their activities would be less. They will always need a supervisor, so be it parents, guardians. If they are busy, they will miss out on their sessions. They will not be able to attend sessions on their own, so that they are easily bored. So then there are vast number of issues may result in lack of learning of certain life skill. So this is something which I have seen a lot. What happens is these kids may not have achieved a certain milestone at a certain age, and probably when they have to write. So a lack in gripping results in a lack of holding the pencil, and then that translates in a problem related to writing. So they might not be able to start writing at a certain age. Similarly, eating, bathing, dressing up, buttoning, all those issues can result in problems during certain life skills. So now these limitation leads to children avoiding certain play. There have been a lot of kids and cases telling me that, what happens with us is we don't want to do it. Like I have a person, like I had an incident with a child where she told me that she used to open the bottle of her paint with her mouth. So one hand and one mouth. But now because of COVID, they are in UAE, so the physical schools have started, but there's a compulsion to wear the mask. So when she now wears the mask, she cannot put the paint, or you cannot use her mouth to open it. And one day accidentally she tried doing it and the entire paint spilled on her mouth, which was quite embarrassing for the child. So how do we help them? How do we, these things are from the kid itself. She's just 8 years old. And to have such a psychological impact is really disheartening. And it's really embarrassing. So she has stopped painting altogether just in the school, So she wants to paint only at home now. So which is not a very good thing, I would say. So why splints? My topic says splints and therapeutic aid. So first, let me cover some splints. So why splints? So it seems that a low load, prolonged stretch is easier for a child to tolerate as compared to a short duration stretch, which is of a higher intensity. So when they come to our therapy sessions, therapists have a tendency to, stretch it out and everything. The intensity in such sessions would be generally a slight higher, which might be a little painful for the child or something. But with splints, we can reduce that, but we can increase the intensity, duration of wearing it. So the intensity is less and the duration is longer. So that is easier tolerated by the child. The other thing is splint can be worn anytime and anywhere. You don't need a therapist for it. You just take it and they can travel with it. They can wear it during their travel time. They can wear it in their school bus. They can wear it in their schools, or whenever they are doing their activities, they can wear it. Then child can engage in play with splints on. So if it's the affected hand, they're wearing their splint and they can still perform and play. They can still play different sports and everything. So that also helps. Other thing is splints, functional splint support movements otherwise not possible. I will show you examples of it. So some functional splints will help the child do certain movements which will allow them to participate in multiple hobbies or their work. And this splints can help in reducing co-contractions. So some of the commonly used splints are shoulder external rotation splint, as you can see. Then there's an elbow extension splint, pronation, supination splints. These are all the splints that I have personally made. Then there's the resting hand splint. It can be put, the MCPs can be put into mild flexion or completely extended. Then there's an outrigger splint, commonly given in radial palsies. And there's this functional Cockup splint. So the functional Cockup splint, as you can see, it's used for keeping the wrist slightly extended, and the volar surface doesn't have any material, and the fingers and everything is free. So the child can maintain a proper position and grasp onto things more easily. Whereas when our wrist is flexed, we tend to drop things more. So the chances here of dropping things would be less, and this is how this splint helps. And that the dorsal nature of the splint and no material in the front is what makes it different from the traditional Cockup splints. So now I come to the main part, my majority of my work, that is therapeutic aids. What are these therapeutic aids? Therapeutic and aids. So anything that aids in doing therapies are therapeutic aids. So what does it do? Why does it help? These are more targeted, so we can do really targeted activities using these aids. These are very customizable. It can be made for every patient, any child, any problem. They just have to let us know. We try a few methods of what will work for them, what will not work for them, and we can customize them. Activities through these I have personally felt are more fun, and gradations are possible, so we can increase the difficulty and decrease the difficulty as necessary. And this significantly reduces trick movements. I'll show you videos how it's possible. And there's infinite numbers of possibilities through these therapeutic aids. So I go on to first, this is the CIMT strap. So CIMT, constraint induced movement therapy, is a very commonly used therapy during stroke. So I tried using this for brachial plexus. It has evidence supporting the use in brachial plexus injuries as well. I personally use it for really young kids, because when a child starts to grow, they tend to remove it off, or they'll be more agitated. But I've seen a few kids who have evenly have tolerated pretty well as well at a good age. So the duration of use of this could be easily 3 to 4 hours, starting with 30-minute intervals. And the same strap can be used to restrict co-contractions and abductions while performing activities of the affected hand as well. So as you can see, the affected hand of this kid is being strapped, and now we are promoting play through the affected hand. And you can give activities, and you can introduce a lot of play. This was the first time the child was using it, so we have kept it at a low level. Slowly we can increase the height of the play, keep a stool on it, start doing activities there, probably increase a little more, and slowly we keep on increasing the difficulty of the activity. So the benefit here is that the child will not move it. The child will not be able to use the unaffected hand. So now it helps in getting the initiations, the push, the initial push. So this is what I use the CIMT strap for. And how do I increase compliance? Because it's really difficult when you tie one part of one hand, which is very well working. So basically we start for lower duration and increase the duration gradually. We tend to use the favorite activities and toys. We talk to the parents that, what are the favorite toys, what are the favorite activities, is there something that the child likes to really eat and enjoy. So we use all those things and try to incorporate them with the strap, so that it's a little more comfortable, convenient, and the child is a little more motivated to do it. And obviously we can use positive reinforcements like treats and things after the performance of the activity, after the child removes the strap. Moving on to the next thing, the idea of this strap came when I saw a very commonly used activities by a lot of parents for internal rotation. They generally take a cloth clip, which we use to hang our cloths, and they put it on the cloth of the child. And now they ask the child to internally rotate and take the clip off. The problem with that becomes, is the child, when they go back, they might go a little back and they start pulling their shirt down from the back using their fingers. That's where the compensation happens. They're just trying to pull the shirt or trying to move the shirt outwards. They're not really going up in the range. So for that purpose, I had designed this simple strap. It can go around the waist comfortably. The first picture that you see is one with pockets, and the other one is with velcros. It's multi-purpose. It can be used as a cross strap. It can be used as a strap for the internal rotation. Even the straps can be the pocket part could be bought in front and used to touch the tummy and reach and remove activities. You can adjust the height. You can go from easy lower levels to going more towards the upper thorax to increase the difficulty. That is how you can do. You can do multiple planes of movement in sitting position, in supine, in prone position. We can do it to increase the difficulty, and with some, we can use different toys for this, and we can make it a fun activity. So I'll show you a video here. So this is the same activity. I have kept a toy which is stuck with Velcro, and the child is now trying to reach. So you can see that the child cannot tug on the t-shirt and bring the belt down. They try to compensate a little bit. So this is a slightly difficult activity in lying down position. And the same when done by the same child in sitting position will be slightly more easier. But here the compensation of pulling the t-shirt down or anything is gone. So that's what I designed it through. That was the inspiration for the design. Then this is pronation and supination band. This is one simple strap of band which can be used in both either pronation or to help supination. This is how I use the strap. So the strap, I have a strap and I stick a small bowl to it, put some toys in it and ask the child to supinate. The idea struck when I saw children compensating through fingers. So they would not supinate completely, rather they would try to bring their thumb and index finger down and pick up things. That's how, to remove any compensation from the wrist and the finger, I had tried to design this. It's a single band. It can be used both for supination as well as pronation. It can be clubbed with multiple games, and there is a possibility of gradation. So to make it easier, we can put it more on the dorsal side and slowly come slightly on the lateral aspect and then come towards the volar aspect to increase the difficulty. Again, as I said, it removes the possibility of compensation from the wrist and the fingers. The same band I use sometimes with flashcards to pick up flashcards. This is another strap which goes around the hand, and you can put spoons or you can put pencils and the child has to drop it down. And in the next picture, you see some sponge, stamp sponge. You can stick the stamp sponge on the strap, and then the child can paint and stamp through it, which again is a fun activity for the child. Then I go to wrist extension activity. This is again made for wrist extension. To promote wrist extension, again, it removes all compensation from all other joints. And the way I perform it is, so basically I put on the activity 8. I drop some object and the child has to grab it. We can do it in either a gravity eliminated plane if the strength in the muscle is really less, or we can do it in against gravity. We can add rubber bands around the MCPs to increase the resistance. And we can put a strap around just to be a finger activity so that it's just a finger activity and can be done in different planes. It can be graded for range as well. So the strap that you see right now on the picture, you see it's almost just 5 degrees or 10 degrees of extension. We can increase the extension of the splint itself. So the child now cannot go lower than that 15 degrees and has to go beyond that 15, 20, 30 degrees to open up and grab the toy. This is another grasping aid. So this was made for a child. I was very confused that the child doesn't have any grasp whatsoever. And a lot of activities for them had become really difficult. The child was unable to play with a lot of toys because most of our things require grasping. So anything that I was doing with the child was without grasp. So then I thought of something, and I thought that I can make a small grasping device which can help the child fold the fingers onto the device and it holds. So with that, it really helped the child. We were able to play a lot more games without the fear of the object falling down on from the child's hand and hitting the face or falling down and the child getting embarrassed. So this really helped the child in the possibility of doing various activities. So uh, then we went on to use the same for a lot of assistant in ADL. So like if they want to hold a brush, they can hold it and grab it and tighten it and then start brushing. So we used it in assisting in ADL, and obviously it assisted us in therapy. So my overall experience has been that this has come in handy with a lot of my physical sessions. So obviously I have a set of all these at my center, and I do use them for all therapies. I keep mixing 2 or 3 things. Sometimes I can use the extension splint with the supination band, so keep the elbow in extension and then do supination. Sometimes I do it without the elbow splint so that it's flexed and then we do it. So this is one of the things. Then parents also find it easier to do these activities because it's with them. They know it. It's easy. I just say put on the strap here, stick the toy there, and let them take it. You don't have to hold them here or try to come. The child is tugging on the t-shirt, pulling it down, so the parent will be pulling the t-shirt up again to not let the child do that. So all those things go away. It's easier for them. They can more easily follow these instructions. Then there's endless possibility for designs. One design leads to the other. So not necessarily that a child that does not have a grasp cannot use the internal rotation band and pull out toys. We can always put a strap with Velcro here, and they can just go and pull it with the Velcro also off. And I have seen that because of the pandemic, online sessions have become like a really common thing. They are more easier to do online sessions. They are more effective. The online sessions have also become more effective. The parent just generally sends in measurements. I make it and can be easily delivered through courier services. And then the session becomes more effective because, it's easier to follow. And that's how I've come through it. So any questions, please let me know. Thank you.
Paurvi, that was outstanding, very creative. I loved all your innovations, but my favorite is definitely the pronation supination strap. So outstanding work. Keep up the good work. I think we're keeping the questions and answers for the very end of the session. So I am actually going to introduce our next presenter, Vinoth Kumar, who's an occupational therapist and also specializes in hand and musculoskeletal conditions. He obtained his graduation and post-graduation both from Manipal Academy of Higher Education and holds a certification in splinting. He currently works as a lecturer at the Department of Occupational Therapy at Sri Ramchandra Institute of Higher Education and Research in Chennai. His entrepreneurial journey led him to setting up his own enterprise for hand rehab and is the co-founder of Ignite Rehab in Arakonam, Tamil Nadu. He is involved in conducting instructional webinars and workshops on hand. His area of clinical interest is hand rehabilitation and splinting. So with this, I hand it over to you, Vinoth.
Vinoth, you're muted.
Vinoth, we can't hear you and you can't see the slides, please.
Can you see my screen and can you hear me, sir?
Yeah, fine. The screen is okay now. We can hear you now. Can you start it?
Yeah.
Yeah, perfect. Yeah, please go ahead.
Yeah. So I'm Vinoth Kumar. So currently I'm working in. Okay, so sir, can you see the screen fully, sir? Yeah.
Excellent. Please go ahead.
Yeah. Okay, so I'm Vinoth Kumar. So I will be talking about the role of splinting in flexor tendon repair today. So some of the common complications we deal with flexor tendon repair is the adhesion or the contracture. It's a common complication we deal when we are when there is a flexor tendon repair when it comes to rehabilitation. Our common goal. So excuse me for the technical problem that is happening. Okay. Fine. So in flexor tendon rehabilitation, some of the common one of the most common complication is the contracture or the adhesion. So, so splint is one of the best modality to deal with these things. So when we use it correctly in the flexor tendon repair. So even I remember one of the famous surgeons in China, he told that to his student saying that to all the surgery end by after doing this repair. But when it comes to hand, the treatment, the actual treatment starts after the repair. So that's why the rehabilitation plays a major part when it comes to repair of flexor tendon repair or any tendon injury. So one of the common goal is to protect the repair as well as to restore the tensile strength of the flexor tendon as well as to promote the tendon gliding. So for this, various surgeons uses different modalities, different approaches for it. So there are common three approaches which they use after tendon repair. One is immobilization, early passive mobilization, early active mobilization. These three are different protocols. So in immobilization, mostly the patient will be immobilized in splint for more than 3 to 4 weeks. After that, the early passive, the passive mobilization or active mobilization will start. But whereas in early passive mobilization, the passive mobilization will start within the first week of after the repair. So there will be a controlled passive movement will be initiated when the early passive mobilization protocol is followed. And there is also active mobilization protocol. In this, after a week of time, there will be active contraction of flexor tendon will be encouraged in this protocol. So these are the common three types of techniques that will be used in the rehabilitation. So among all these three things, the splint has a major role in all the three protocols. So I will be explaining like how it will be. Okay. So this is a common post-operative splint that we use after flexor tendon repair. So this is a dorsal block splint. Okay. So it will be used for 0 to 3 weeks. So in that, the wrist will be positioned in 10 to 30 degree of flexion initially. Then MCP will be placed in 40 to 60 degree of flexion, and IP will be flexed, and then it will be casted with this position initially for 0 to 3 weeks after the repair. But there will be it will come to the intermediate stage between 3 to 4 weeks. the position of the wrist will be changed to neutral degree. So when in the immediate stage, the patient will be wearing this splint for like almost all the time, 24 hours. But when the patient comes to the intermediate stage, like that is 3 to 4 weeks after the repair, there will be weekly removal of the hourly removal of splints will be there. In the immediate when the patient comes to the late stage, after 4 weeks, the corrective splints will be introduced. This is a common splint for flexor tendon repair. And there is also Clenet splint. So these splints are used for, as I mentioned earlier, it is used for early passive mobilization protocol. So these splints, it allows the passive, it keeps the repaired tendon in the completely flexed position, and there will be controlled active extension will be encouraged in these splints. So this is a splint that will be used for there is a flexor policy along with repair was done along with the flexor tendon, flexor digital superficialis, and flexor digital profundus tendon. So this is a splint. This is a modified dorsal splint which has some component to protect the flexor pollicis longus too. Yeah. So when it comes to rehabilitation part, so we introduce a splint in a much different way than what is happening. So we follow that early passive mobilization or early active mobilization protocol when we introduce the splint in rehabilitation. So after the patient comes to the rehabilitation stage or after 4 weeks of the immobilization, either with the dorsal block or Clenet splint or any other splint. So initially we introduce this short pan splint, which corrects the stiffness in MCP and other IP joints, like the extensor contraction that has happened in MCP and the IP joint. These splint takes care of it to correct it. So you can see this aluminum splint, it is modifiable splint. So what will happen is when the patient is coming to the therapy area in the rehabilitation stage, we initially introduce this splint with the whatever the patient comfortable limit. So say the patient has a comfortable limit of say 40 degree of MCP extension or 60 degree of MCP extension. So we keep that angle, we give the stretch only to 65 to 70 degree initially. We keep that angle in such a way that, modify the angle in such a way that only the 5 degree or 10 degree stretch is produced initially. Then laterally the angles will be changed. So then the patient, like that, so it improves the patient's compliance to the splint as well as it produces a faster. Since the stretch is going on almost 24 hours a day, also it is giving the stretch 24 hours. So this also a splint used to manage the contractures, most probably extensor contractures. So the stiffness that is happening, that will happen on the IP joint. So this is used to correct the stiffness or the extensor contracture that happens in the IP joint. This is a finger-based flexion strap. So the same as the short pan splint, this also has the limit. So we keep in such a way that the patient's comfortable limit or the limit the tendon should, the force that the tendon should tolerate. So we keep that initially, then later we change we pull this strap so that it tightens it. So same as a short pan splint, the more compliance it has when we give to the patient. So this is long pan splint. So this is used to correct the tightness of the flexor tendon repair. So this extends the wrist along with the fingers, the flexor contracture that happens after the flexor tendon repair. So this splint, it takes care of the wrist correction, wrist contracture as well as the fingers contracture. So it same as the splint that is done for short pan and finger strap. This also has the angle. So we can change the angle according to us. So whatever the angle, whatever the stretch, the tendon should have. So whatever the stretch it should be given. So we give that much limit initially and later we change the angle. So that's how we go a bit. Also, we usually give the short pan splint initially, then later we go for the long pan splint. So to manage the stiffness and tightness on the go. So along with the corrective splint, we also make the, as Paurvi Madam has mentioned, the therapeutic aids. I also make the strengthening activities or the home program activities. Mostly these activities will be given as a home program. So the therapy will happen even at the home. So you see the splint, initially there was a positional splint. There was then it was a corrective splint, corrective contracture. There was also this splint, so this active stretching or active strengthening. So these are made device for this patient based on their complaint. Say this man told that he wants to return to work as a driver. So this activity was designed so that whatever the problem that was faced in driving, so the main problem we had was to hold the steering. So that was the problem. So this activity was designed for that for returning him to his work as a driver. So this is one of the activities. You can see it. The patient has to hold the fingers flex with that action, and there will be weights that will be hanged in this foot. And we can grade this we can grade this whatever the weight, see like this, like 100 grams, 200 grams we give, and we increase the resistance of it. So these are we increase the strength as so then after to return into the work as a driver. So this is a lateral pinch activity, same as the other, same as this activity. This is also for the strengthening purpose. Yes, this is the stretching activity. So if you see this line, this is made for the active stretching of the wrist joint. So it has this angle which is modifiable, where we can set up the limit. See if the patient has the like we have to extend for 10 degrees, we keep that angle, the target. This is a target. So we keep that for 10 degrees, and then the patient achieves the target and we increase. So this activity will be given as a home program activity. So the patient will keep practicing. So the therapy will continue even at the home, and the more faster outcome is produced. So similarly, this is the finger extension activity. So this is also the same purpose, to increase the active stretching of the flexor tendon. So by this, I end my session. Thank you, and this is my contact number. So if anybody wish to contact me, so I'm located in Arakonam, Tamil Nadu, we can talk. So thank you all.
Thank you, Vinoth, for that wonderful presentation. That was very informative. Now I open this for a question and answer session. So I am looking at my question and answer screen here, and no questions from the audience yet, but I invite the participants to post questions to the entire panel here. I do have a few questions, and I would like to start with Shovan sir. So I'm curious to know, so as to what outcome measures you use to get the patient input regarding the success of the low technology intervention. What outcome measures are you using in India?
Okay. Yeah. It's quite interesting. What we do is we have developed a indigenous method of doing it. Now, whenever we give this device, okay, we use a simple visual analog scale, okay, and so a patient without the device, okay, in order if 0 is the most difficult situation for the patient and 10 is as before, how he was performing the activity as before. So on a scale of 10, how much would he score without the device? Okay, and then with the device, how much he will score. So based on the experience of of having worked this way, a score difference of around 4 points. So supposing if the order of difficulty for writing was 4, without the device, and with the device it is somewhere around 7 and 8. Okay, it is for sure that the device is started to work. Okay, so that is a subjective way of kind of a quick analysis whether the device is working or not.
Yeah, that's very interesting. So the 4-point difference, I think of it as the minimally clinical important difference, the minimum amount of change that has to happen to bring about a functional change that's clinically significant.
Yeah, that is as per the individual's perspective. They decide. So we leave it to them.
Sure. Yeah, no, that
Yeah.
makes sense. They are the ones who are using the device. They are the ones who can truly assess the effectiveness, and they are applying, in several different contexts of their life. Okay, another question I have is, I certainly, do not practice in India, so I'm curious, do patients pay out of these devices out of pocket, or is the insurance system in India now, beginning to, perhaps help out with some of the expenses related to these devices?
No, these devices, since we are in a private hospital, so it is the patient who has to pay for these devices if they are coming as an outpatient. But if they are an inpatient, then part of it is covered.
Okay, and typically, how many times do you see the patient? How many times in a week do they come to you? Perhaps for follow-up therapy, and what's the duration of time that you typically end up seeing these patients? I mean, I'm sure there's a range, but just typically.
Yeah, it would be difficult to tell that because it depends on many factors. Okay, but on an average, a month and a half, that is an average follow-up time that we have in our hand.
Okay, and then do the patients typically come see you a couple of times a week throughout that period?
That is negotiated because it depends on from where the patient is coming, how far the distance, their convenience, their availability of time for them. So, and whether the diagnosis or the typical problem needs him to come to the department on a regular basis or twice a week. So I think so there are multiple factors which we take into account before we come to a decision that what would be the rate at which he is going to report to the department.
That makes sense. I hear you. So now, as you mentioned that, you mostly use aluminum, and there are certainly several advantages you listed, and, perhaps some thermoplastic that you import from abroad. So there's a whole range of thermoplastics, low temperature thermoplastics, and I'm just curious to know which one you have a preferred one, you have a favorite, which ones do you typically import?
Our options are pretty limited. We use Aquaplast.
Okay. Yeah, I like Aquaplast. I would say my favorite is Taylor Splint, but as you know, here in the US, we use a wide range of thermoplastics, and OrphiCast is a new material that we use, and we actually use it to make serial casts for fingers. So Vinoth, you were talking about contractures, in fingers after flexor tendon repairs. So there's certainly an area, several other areas that might lead to a contracture, that's something that we use. Now, unrelated to your presentation, this is just for sort of my general curiosity about the practice in India, documentation. you ask a therapist working in the US, people are scared of spiders and snakes. We're scared of documentation. The amount of time we spend documenting is pretty mind-boggling. So how is it like in India? Are therapists using an electronic medical record to document their evaluation, do a progress note, do a daily note? How does that go?
Is the question to me or?
Yeah, to you. And I welcome the input of the entire panel, but we'll start with you.
Okay. Yes, EMR electronic medical records is coming. It is there in our hospital as well, but only certain areas are covered under EMR. But then they are upgrading the system, I think so, in another maybe sometime next year, first half of next year. Occupational therapy also will be included in that. That means we will directly type into the system and not really handwrite it. But EMR as a practice is coming in a big way in a bigger cities, big hospitals. So it is already into practice. For occupational therapists, yes, I am not sure whether OTs are using it as of now. At least in our hospital, we haven't started. But it will be another 6 months, 8 months. By the end of 2022, I think so, we are into the system.
Okay. Well, Paurvi and Vinoth, any of you would like to share your input with regards to EMRs?
So, ma'am, I have not seen it that much in private practice as in clinics and all, because these kinds of systems are a little expensive for just a single-handed person to afford. But in bigger corporate hospitals, because everything happens, if a doctor wants to read something, they would not look up for a file or a physical file. So I have seen and I have entered into systems, but they're not very detailed. They'll just ask the duration of therapy, what time the patient entered, what time they left, what did they do in brief, like about 100 words, something, and anything unusual that happened, like if there's an incident or something, you have to report that there. So we do that in a lot of corporate hospitals now, yes, but it depends to which extent. Some places only ask for the duration and what you did in the session, and some places are a little more detailed, so the doctor can look into it and see. But private practices, as in like, if you would ask my own clinic or anything, right now, not that much. It's more of a written thing. Like if you want, we give a diary to the patient where, we can write it.
Sure.
Yeah.
Yeah. Wonderful. Yeah. Okay.
So I work in more of kind of small towns, more of rural population. Over there, this digital is not much famous. Like digital or using the internet to see the medical records, people are not that much great. So in India, this is also common that in private practice it is really difficult to bring it to digital as of now. But yet, in future can be one of the things to try in India. That's my perspective on it.
Okay. Well, thank you. So now, Paurvi, this next question is for you. What's the incidence of birth-related brachial plexus injury cases in India?
Ma'am, it would be around, it depends. It's a rather common incidence, I would say, but not very common. What I recently read in the stats was 0.9 to 3 per 1,000 live births. But what happens is, I do get a lot of brachial plexus because, once you start seeing one genre of patients, you get that a lot. So for me personally, more than any other hand trauma, I have seen birth-related brachial plexus the most. But the statistics officially is 0.9 to 3 per 1,000 live births.
Okay, thank you. Now, you mentioned that, you use different strategies to improve compliance, both on part of the patient and, giving some tips to the family. Do you also use maybe an award system or positive reinforcement, for maybe older kids?
Yeah, no, even for younger kids, I've seen it really works. It would be more of food and treat items for the younger kids, and for the adult, like a token economy or, a positive reinforcement in terms of an outing, an
Right.
activity that works more for the older population. And for younger kids, even I would say around 3, I start introducing, but because there's where the child starts understanding reinforcements, that cause and effect relationship, that I'm doing this and I'm getting that. So below that, it has to be a little more passive. That's why I actually thought that what I can do to make it more active for kids below the age of 3 years, there's where I got the idea of the CIMT strap. So
Right.
traits and all do work for sure.
Great. Yeah, wonderful. Okay, so now my next set of questions will be for the entire panel. So I'm curious to know, so as to, when it comes to flexor tendon injuries, what kind of repairs are surgeons doing in India?
What I have seen around is the 4-stranded repair. Is the most common. The modified Kesslers and those repairs are more common. I have worked in St. John's Hospital. So when I asked the doctor, they said they do a 4-stranded repair with a box stitch on the tendons, the epitendon, this thing. So that is what I have seen. I've not heard many people doing 6-stranded. I'm really sorry if I am not unaware of it, but in my personal opinion, with my colleagues who I have asked, 2-stranded or 4-stranded, but mostly 4-stranded.
Okay, so now for the patients who have a 4-strand repair with a running epitendinous suture and perhaps bending for the pulleys, do you guys are they referred to you guys for therapy early on, let's say perhaps within the 3 to 5 a day window period, that's the optimal for starting early active motion?
Yeah, I have seen them. A lot of it happens more for the adult population because it's a little more safer for the child to just win the cast. So that's what I have seen. But there are a lot of surgeons who do appreciate a day 2 or a day 3. One slight bit of a swelling and inflammation comes down, and very supervised, like really supervised. You have to be like eye to eye with them. You cannot remove your eyes off them. And then slowly and gradually, they keep them for 2-3 days to learn some little bit of therapy, and then come as outpatients. But yes, I have had the opportunity to personally experience when the patient is sent even on day 2 or 3. Yeah, I have had that.
Right. Okay, so no, that's wonderful, because that's what we mostly do here. Our surgeons do 4-strand, 6-strand repair with epitendinous sutures, pulley bending, and you certainly need the right kind of patient. Somebody who's very motivated, who is going to be very careful, somebody who's going to follow their precautions. Certainly children, they do better with the immobilization protocol, although I have used the early active motion for kids as young as 11 years old. If they present a certain level of maturity, they tend to do really well. So now when it comes to a splint for early active motion, what angles are you putting the wrist and MCP joints in?
Early active, I have personally not seen too many. It's more of early passive, so the clean-outs protocol, and it's very in keeping with the surgeon. So before deciding any angles, it's always the best to just give a call to the surgeon and ask them, is it allowed to keep the wrist in neutral, or would you want it in slight flexion? We try and avoid slight flexion. We try to keep it neutral, and then MCPs bend to 90 and then IPs extended. That's the common approach. And if the FPL is involved, then it's a palmar abduction, like a neutral thumb position, and then start with gentle passive. I have not seen very frequent early active protocols. I think India is still a little conservative over early active because, it's not, the therapist or the surgeon's mistake or anything, but the patient itself, either they get too aggressive with it, or either they might be really careless with the splint. So the care is always there, the follow-up, because in India, a lot of patients do not have follow-up, and the insurance, doesn't pay for more than 180 degrees or 180 days or something. And there's this policy 60 days or post-op or something like that, and they might have ended up their insurance balance by the time you come to therapy. So then they're not really very keen on the follow-up, very regular and diligent. So that's why keeping it on the safe side, I have mostly seen early passive.
I see. Yeah, I do think that we need to get to the point where the insurance companies don't dictate therapy. They're not clinicians. We run into those problems, even in the US. But, with the advancements made in, the repair itself, lends itself to the opportunity to do early active motion, which is going to reduce the scarring on the inside of the tendon. You get better tendon glide. It reduces the incidence of flexion contracture. So then you're actually avoiding the whole range of complications that come, due to these other issues. And I think patient education is key. I think that, empowering patients, educating them, people have a huge potential to understand. So there's a huge, I see that, there's a huge opportunity, to perhaps advance this in India, certainly keeping in mind, the challenges along the way. But yeah, it would be very, I would be curious to see where the practice goes over the next 10 years. Yeah. Let's see, there are no questions in the question and answer panel here. So Dr. Terrence, how are we doing with time?
Yeah, we are driving to home and we are driving towards the end. Thanks for your efficient and diligent moderation. I think I'm really amazed about the way you conducted this webinar. I was just enjoying, and the way you have dealt with the introduction of speakers. In fact, moderating the question and answers and communicating with the panelists. I think really you have a great scope, being a great moderator in the future. Thank you very much. Thank you, Dr. Shovan, for your excellent and an incredible talk. I was really taken back, and we actually knew little about the work you do. This one platform which really opened up how much effort and how much mind work you put on. It's not that making a plastic splint. It's completely just comes from your mind, and especially as you mentioned, according to the capability and the capacity of the patient. It's not that you made a dynamic splint or or a static splint. It's according to the deformity where you make a splint, and you absolutely change the lives of the patient. And all those pictures and videos are amazing, especially the snake charmer. I think that it's a wonderful and incredible job you have been doing. I think at this time I can only say that you need more power to continue to do this. Thanks, Dr. Paurvi, for your amazing talk on brachial plexus birth palsy. We as a surgeon, we only focus on surgery and treatment. But then we also realized today that you are amazingly making it more easier pre-operative and also post-operative. All internotation splints and pronation, amazing splint about pronation, supination activities. I think it's eye-opener for all hand surgeons to utilize your proficiency and your work on this brachial plexus birth palsy. And last but not least, Vinoth, I think you completely narrated all those treatment modalities, especially the passive therapy, dynamic, active, and also the static sprints of post-operative flexor and repair. Really a wonderful session today. All I can say is I enjoyed a lot, and especially I learned a lot. So a big thank you for all of you who have been sharing your time, valuable time. I know Dr. Shaw is very busy being a president of the society, and also Aditi sharing your time today, especially for us. Thank you one and all. we'll be having some questions. Probably we can post them in your email, and then they can communicate to the email. That's for today. Stay safe, and we hope to meet you all soon once the pandemic goes. Special thanks to Aditi for excellent moderation. Thank you all. A good night and morning.
Thank you.
Thank you, sir.
Thank you,
Everyone. Bye.
Thank you all.